Assalamu alaikum. Our topic today is about cancer of the large bowels, colorectal cancer. Colorectal cancer is the third most common cancer in males after prostate and lung cancer, and the second most common cancer in females after breast cancer. It is the third cause of cancer death worldwide. However, the incidence and mortality vary uh, based on country and location. The incidence of colorectal cancer has been increasing in young population age of less than 50. Predominantly, those patients are diagnosed with left-sided and rectal cancer. Unfortunately, the majority of them, more than 86%, they do present with symptomatic and advanced stage disease and, of course, poorer outcomes. Having said that, any young patient presents with blood in stool or rectal pain, or even if found to have iron deficiency anemia, they should be thoroughly investigated with good history and physical and sometimes colonoscopy. Presentation of colorectal cancer. Patients with colorectal cancer present with symptoms or signs, and typically of those patients present with symptoms or signs, it is advanced stage disease. And the symptoms are typically change in bowel habits, irregular bowels, most likely constipation, and this is the most common symptom, hematochezia, blood in stool, and this is typically for rectosigmoid, tenesmus, rectal pain, stool small caliber. This is for rectal cancer, abdominal pain, the least common, and sometimes iron deficiency anemia detected during routine checkup. In countries where colonoscopy is becoming a routine, the presentation is actually during colonoscopy and usually early stage colorectal cancer. Unfortunately, some patients do present with some emergency symptoms, like for bowel obstruction, and this is for, we see this in patients with upper core tumor. The patient may present with perforation or bleeding. There are unusual presentation for colorectal cancer, and this is due to local invasion or perforation, which may lead to fistula, and the fistula could be with the bladder. Those patients presents with pneumaturia, or fistula with small bowel, or fistula, intra-abdominal fistula with the connection to the retroperitoneum, abdominal wall, or liver, when the patient presents, those patients present with an abscess and fever of unknown origin. The organism are usually Streptococcus bovis or Clostridium septicum, or extra abdominal anaerobes, Bacteroides fragilis. Risk factors for colorectal cancer. There are three categories of risk factors for this disease. Factors influence screening, that alter screening. Factors do not alter screening, and factors may or may not influence colorectal cancer screening. Just go over those categories. Factors influence screening. Number one, genetic factors, mainly Lynch syndrome, hereditary non-polyposis colorectal cancer, HNPCC, and familial adenomatous polyposis, FAP. Second, personal or family history of sporadic colorectal cancer or adenomatous polyps. Third, inflammatory bowel disease, ulcerative colitis, and Crohn's disease. Uh, Patients with ulcerative colitis, especially the ones with pancolitis, they are at higher risk for colorectal cancer, and their risk is in the range of 5 to 15 folds compared to an average person. And the risk of colorectal cancer begins 8 to 10 years after diagnosis of pancolitis and 15 to 20 years for left-sided colitis. Regarding Crohn's disease, data is limited, so there is not enough data. However, we consider the risk is pretty much similar, especially if more than 1/3 of colon is involved. Number 4, patient exposed to abdominopelvic radiation, such as women who may receive radiation for GYN malignancy, and patients with cystic fibrosis. This slide shows the risk factors for the other two categories, which is really not that important in regard to the screening program. So let's just talk about the genetic risk factor. And this is led by Lynch syndrome, because there are other syndromes, but the most common or more known is the Lynch syndrome. 20 to 70% lifetime risk of colorectal cancer related to Lynch syndrome, or the Lynch syndrome patient, they have high risk. We can say the risk is 25 to 70% in their lifetime for colorectal cancer. Lynch syndrome is an autosomal dominant disease, and those are the genes mutated in this disease. Also was noted that Lynch syndrome is associated with MSI, microsatellite instability is typically high instead of stable or low, and there is deficiency of MMR, mismatch repair of the DNA. So tumor, these are on the tumor, not the blood. This is in the tissue itself. So patients with MSI high or deficient MMR typically have Lynch syndrome or inherited colorectal cancer. However, there is up to 15% of colorectal cancers are sporadic, and still they have the MSI high or deficient MMR, so they are not Lynch. So we have to be careful when we see the result of those. Familial adenomatous polyposis, FAP. It is an autosomal dominant disease, and the gene is called adenomatous polyposis coli, APC gene. And the APC gene localized to the long arm of chromosome 5, location 21. Patient with FAP, they are at very high risk for colorectal cancer. So you can imagine 50% of patients with this condition will develop adenomas by the age of 15, and 95% risk of developing adenomas by age of 35. 90%, and they are at 90% risk for colorectal cancer by age of 45. So that's why the screening has been altered for this group of patients. So let's just talk about the screening. For an average patient not known to have risk for colorectal cancer, those patients, we scan them at age of 50, typically at age of 50, unless they have one of the risk factors, of course. History of inflammatory bowel disease, history of abdominal radiation, family history or predisposing inherited syndrome like Lynch syndrome or FAP. However, the United States Preventive Service Task Force, USPSTF, American loves the abbreviations, and the American Cancer Society, American Cancer Society, they recommend screening at age of 45. So now the recommendation is to screen from starting at age of 45 for the average patient without risk. The screening is colonoscopy. Typically, the screening is colonoscopy, which is the standard of care, which is the best choice for screening. And it starts at age of 50 up to age of 75, but now we can say from 45 to 50. What about patients older than 75, 76 and up? Those patients, we screen them case by case, individualized. So the colonoscopy is normal. Then we do recommend to repeat colonoscopy every 10 years until age of 75. After that, case by case. Of course, colonoscopy is not perfect, and there is no test ever perfect, but the miss rate is very low, 2 to 6% only in the very experienced physician. What if the colonoscopy shows adenomas or serrated polyps? Just by the way, usually tattooing is done at the end of the at the time of colonoscopy to mark the site removed polyp. So if 1 to 2 small polyps less than 10 millimeter, 1 centimeter, then we repeat colonoscopy in 7 to 10 years. 3 to 4 polyps, tubular polyps, it has to be tubular polyps, small tubular polyps. Then we recommend to repeat colonoscopy in 3 to 5 years for advanced adenomas, more than a centimeter size, or adenoma with high-grade dysplasia, or tubulvillous adenoma, or villous adenoma, or if the polyps removed are 5 to 10, still small, less than a centimeter, then we do recommend to repeat colonoscopy in 3 years. For more than 10 adenomas or on a single exam, we repeat colonoscopy in 1 year. In any case, if more than 10 adenomas on a single exam or more than 10 cumulative adenomas removed in lifetime, those patients should be evaluated for hereditary colorectal syndrome. Adenoma more than 2 centimeters in size, that removed in a piecemeal, the colonoscopy should be repeated in 6 months. What about high-risk patient? How we screen them? Those are the group influence or alter the screening. So, patient with Lynch syndrome, HNPCC colorectal or colorectal cancer. For those patients documented to have syndrome, we do colonoscopy annually at age of 20 to 25, or 2 to 3 years prior to earliest age of colorectal cancer in family. If colon cancer or unresectable adenoma is found, then those patients should be taken for total colectomy with ileorectal anastomosis. Patient diagnosed with rectal cancer, on the other hand, should have proctocolectomy with ileal pouch anal anastomosis. Following the surgery for colorectal cancer, if still they have the rectum or they have the part of the colon, they should have annual endoscopy. In addition to the annual endoscopy, those patients, we should screen them for uterine and ovarian cancer. However, there is no recognized screening for those type of cancer, but it is based on the physician and the patient. They can choose some kind of screening, either ultrasound or CA125 for ovarian cancer, but there is no recognized screening program for those cancer. Those patients also should have an EGD with gastric biopsy at age of 30 to 35, and then every 2 to 3 years. And they should have an annual urine analysis for hematuria because they're at risk for kidney cancer, and that is at age of 30 to 35. What about familial adenomatous polyposis, FAP? For this group of people, we should do annual flex sigmoidoscopy or colonoscopy at young age, 10 to 12, very young. And if they develop cancer if they develop cancer at any time, we do total colectomy, and we do EGD at onset of colonic polyps or at age of 20 to 35. Patients with family history of colorectal cancer or advanced polyps, if any one or more first-degree relative diagnosed at any age with colorectal cancer or advanced polyps, then we screen the patient at age of 40, the relative at age of 40, or 10 years before first-degree relatives diagnosis, and then colonoscopy every 5 years. Other rare condition, juvenile polyposis syndrome, colonoscopy at age of 12, then annually if polyp, or 2 to 3 years if no polyps, or every 2 to 3 years if no polyps. Of course, if they develop cancer, we do total colectomy. Patient with Cowden syndrome, PTN gene mutation, hematoma tumor syndrome, PHTS. Those patients at risk for other cancer besides colorectal cancer, at risk of thyroid cancer, kidney cancer, the breast cancer, endometrial cancer. So this is the list of the screening, but at least we should do colonoscopy for them at age of 35 and then every 5 years. Patients with MUTYH gene mutation associated polyposis, MAP, we do colonoscopy at age of 20 to 30, and then every 1 to 2 years, EGD at age of 30 to 35. These are the other screening tests. Simple tests. They don't replace colonoscopy, but in some countries where the screening colonoscopy is not available, they have a big role. Fecal immunochemical testing. This is a single sample test done annually. Guaiac test, focal ocal blood, 3 samples done annually, and then Cologuard, multi-target stool DNA test. More specific, however, the test is not very pleasant for patient and for the lab, because the patient has to collect a large amount of stool. It's not just a little bit of sample. It should be in a container. Computed tomography colonography, CTC, it is CT scan. It's done every 5 years. Sigmoidoscopy every 5 to 10 years, and then combination of sigmoidoscopy and stool for ocal blood. PILCAM capsule colonoscopy is done every 5 years. Diagnosis: the colorectal cancer patient present with as we said, with symptoms that may lead to diagnosis, or the diagnosis is after, or diagnosis made after colonoscopy, at the time when the patient has a polyp removed or a tumor found and a biopsy taken, and usually it is an adenocarcinoma, or sometimes fecal occult blood positive or other simple screening test that may lead to the diagnosis. But the diagnosis really rely on biopsy, and the histopathology is an adenoma, not a squamous cell carcinoma like other cancers, but it is an adenocarcinoma. In the next slide, we'll talk about the histopathology. Remember, CEA, or carcinoembryonic antigen, is not a diagnostic test for colorectal cancer. It is a test for prognosis, so it does have a prognostic feature, but not diagnostic. Histopathology. Colorectal cancer is typically carcinoma, and more than 90% of the carcinoma are adenocarcinoma, some of them mucinous and some single ring cell type, in addition to other rare subtypes. Immunohistochemistry to confirm the diagnosis is CK20 and CDX2 positive and CK7 negative. After that, the pathologist will give you the grade, and typically they do mismatch repair MMR to decide if deficient, as we said before, and they also may do the MSI, microsatellite instability, to see if it is stable or high, and it is, then they go ahead and do BRAF testing, basically to see if the cancer is hereditary or not, if they need to do Lynch syndrome genes or not. So, other types are neuroendocrine, hematoma, mesenchymal tumor, and lymphomas. But again, the most common is the carcinoma, and among the carcinoma is adenocarcinoma more than 90% of the time. This is just this cartoon is, or diagram, just to as a reminder for the histopathology of the colorectal wall. It is made. This is the lumen. This is the outside. This is the inside of the colon. This is the lumen. It is made of the mucosa, lamina propria, muscularis mucosa, and the glandular tissue. These are the glands. The green one, the goblet cells produce the mucin, and this is the submucosa. The muscle, this is circular layer of muscle. This is a longitudinal muscle. This both of them form the muscularis propria, then the serosa and the subserosa, and the submucosa and subserosa contain the nerves, the arteries, the vascular structures, arteries, veins, and lymphatic channels. So I want to show you this because this is very important for the staging. Because colorectal cancer staging does not rely on the size of the tumor. Like breast cancer, lung cancer, usually we talk about how big is the tumor. Here is really not about how big is the tumor. It is about the depth of the tumor, and it is growth and penetration through the wall. So it could be a small tumor penetrate deep, and that's a higher stage. It could be a very big tumor, and it stays inside the colon without penetrating the wall, deep into the wall, and they're considered early stage tumor. So. After the biopsy is taken, usually it's typically either a malignant polyp, that means cancer cells, it stays within the mucosa, only invade the muscularis mucosa into the submucosa, which we call it pathologic T1. Typically, as I said before, the pathologists perform the immunohistochemistry for MMR or MSI, and if needed, BRAF. So after the polyp is removed, and hopefully it's removed in total, one piece, in block polypectomy. So if it is pedunculated polyp with favorable features and negative margins, we just observe, we don't do anything more, and we repeat colonoscopy based on the size and number of the polyps, as we mentioned before. If it is a sessile polyp with favorable features and negative margins, still we could just observe. Some people do recommend colectomy with block and lymph node dissection, and that's fine. However, if the polyp is removed in pieces, fragmented, or the margin cannot be assessed, pathologist couldn't tell the margin, or the polyp has unfavorable features like poorly differentiated polyp or polyp with lymphovascular invasion, at that point we do more than just observation. We should obtain a CBC, liver function test, CAA, tumor marker, and may consider pelvic MRI, especially if it is a sigmoid or rectal polyp. And we may also order a CT scan of the abdomen and pelvis. At that point, that area should be resected with the colon resection or even hemicolectomy with in-block lymph node dissection. On the other hand, if it is more than just a polyp and the tumor has grown through the wall into the muscularis propria, that's what we call it a pathologic T2, then the story is different. And then we go to the part of the workup, which include, of course, we review the pathology to make sure this is an adenocarcinoma, and we look at the grade, and then the pathologist may perform the MMR, MSI, and if needed, BRAF, as you mentioned before. So pathology, they review very carefully. And this is done typically in a cancer center, is done by in a multidisciplinary discussion at tumor board. Then we review also we need a CBC, review the lab for CBC, liver function test, and also obtain a CA, obtain a CT scan of the chest, abdomen, and pelvis. For the rectal cancer, we need to do an MRI of the pelvis or endoscopic ultrasound for accurate staging, because this is very important for treatment. So the differentiating between rectal cancer and colon cancer is very crucial for treatment, especially if the tumor is in the rectosigmoid area. And why that? Because the treatment is different if it is colon cancer versus rectal cancer. And we have to determine the location of the tumor. Is it in the rectum or in the sigmoid? And that, as I said, could be done by the MRI. MRI of the pelvis is very useful for this purpose. The rectum lies below a virtual line from the sacral promontory to the upper edge of the pubic symphysis. This is the location. This is the exact location of the peritoneal reflection, because The rectum is really not covered by the peritoneum. That's why the treatment is different. And the colon is covered by the peritoneum. So the colon is basically in the retroperitoneum. It's covered by the peritoneum, totally covered. The um, the uh, the rectum is not. So that's why the treatment for rectal cancer is different, and that's why it does include radiation because of the risk of cancer recurrence. In case of metastatic cancer, we do more testing on the tumor. So we do test the tumor for biomarkers, KRAS, NRAS, BRAF, HER2, MMR, and MSI. All these markers they do have actually not only for not for diagnosis or prognosis, but also for therapy. So that's the reason for doing those tests. These are all these biomarkers. They do have therapeutic impact. Also, we do need to do a CT scan, a PET CT scan, and consider liver MRI for liver metastasis, especially if it's limited disease, potentially resected. Staging. Before we go through the staging, I want to remind you with the 3 points when we do the scan for the staging. Any smooth metastatic nodules in the pericolonic, perirectal fat is considered a lymph node, even if we cannot see an actual or find an actual lymph node with lymphatic structure. We call it lymph node. So that's considered an N1. Also, any irregular metastatic nodules in the peritumoral fat, if any deposit of irregular metastatic spot in that area is considered vascular invasion. That means high risk for cancer recurrence. And to call a tumor stage 2, we have to examine 12, at least 12 lymph nodes, find no cancer in any of them to call it a stage 2. So if the surgeon give us 10 or 11 or less lymph nodes, that is not adequate for the staging, and we cannot rely on that to predict cancer recurrence. So, again, remember, the stage of the cancer, it depends on the depth of cancer in the wall. So if the cancer cells are found within the mucosa, not reaching the submucosa, that cancer is called carcinoma in situ, stage 0. But if the cancer penetrates through the wall, through the muscularis mucosa, into the submucosa, that we call it a T1, or into the, and that's a malignant polyp, or if it goes all the way into the muscular propria, that is a T2. So that's still stage 1 disease. On the other hand, if the cancer penetrates all the way through the wall into the serosa, reach the serosa, that is a T3, and that is a stage 2 cancer. But if the cancer, regardless of the penetration, if it reach the lymph node, if the cancer reaches the regional lymph node, any regional lymph node, that is stage 3 cancer. So really, the colon cancer depends on the penetration or reaching the lymph node, not on the. We don't rely on the how big is the tumor in the colon. For example, this is a picture given to me by Dr. Bushra. He encountered this big tumor during, I guess, screening colonoscopy. Not sure, but probably screening colonoscopy. They found this tumor. So we cannot say this is bad or this is good or whatever. It is a tumor. It is a big tumor. It could have cause obstruction or bleeding, or it may cause obstruction or bleeding, but we do need to know how deep this big tumor has grown through the wall. Then we can talk about the risk of recurrence and what to do. This is the stage. This is the TNM staging: tumor, lymph node, and distal metastasis. This is just from stage 0 to stage 4. I'm not going to go through this. This is just a cartoon. This is just a cartoon of the cancer, like from the polyp, the stage 1, stage 2, or stage 3 to the lymph node. This is just like a drawing for the tumor in the liver. This is just an isolated tumor that could be resected. So now let's just go to management of colorectal cancer. Management usually either surgical. So let's just start by the management of non-metastatic cancer, early stage cancer, and we'll start by talking about the colon cancer and then rectal cancer. So for colon cancer, that is resectable, non-obstructing. The best treatment is to go ahead with surgery. It is a hemicolectomy with in-block lymph node dissection. And as we said again, we hope that surgeon will give us minimum of regional lymph nodes for a good prognosis, so we can talk about or predict what could happen to that patient. If a patient presents with unresectable or obstructing tumor, then options are still sometime surgeon goes in, remove the tumor, even with obstruction, especially when they end up in the ER with acute abdomen. Another option is resection with diversion colostomy if it's obstructed, or diversion colostomy without even removing the tumor, or sometimes stent. Eventually, those patients may end up with hemicolectomy with in-block lymph node dissection. But if a patient presents with bulky nodal disease, that a tumor that penetrates and invaded adjacent structure, bladder, retroperitoneum, then those patients, we treat them with the neoadjuvant chemotherapy, pre-operative chemotherapy, combination chemo, and then hopefully they respond before, and then take them for hemicolectomy with in-block lymph node dissection. Patient with unresectable or medically inoperable, not fit for surgery, we treat them with concurrent chemoradiation, reevaluate for conversion to resectable disease if they are lucky. Any role for systemic therapy after surgery, which we call adjuvant therapy. Talk about that. For stage 1 colorectal cancer, no. Surgery done and then just observation. For stage 2, still that the tumor, remember stage 2, a tumor that grows through the wall into the serosa, stage 2, but not to the lymph node. Still, we just observe them. However, there is a subset of stage 2. Those patients have high risk features, including a tumor that invades adjacent structure or organ, tumor that presented with the obstruction or perforation, tumor with poorly differentiated features, tumors with lymphovascular invasion or perineural invasion, or if the surgeon gives us less than 12 lymph nodes, so we don't know. This in the studies, they usually include patients with lymph nodes more than 12 lymph nodes removed at the time of surgery. Those patients, we do offer them chemotherapy. I say offer them chemotherapy, and then it's up to them to take it or not, but we tell them, hey, you are at high risk for cancer recurrence. So we do recommend chemotherapy for them. What about patients with positive lymph nodes, even one lymph node positive? The higher the number of lymph nodes, of course, the higher risk, but at least one lymph node, that's a stage 3 colon cancer. Those patients are at high risk for recurrence, and adjuvant chemotherapy do benefit them. 30% reduction in risk of recurrence, and 20 to 32% reduction in mortality. The chemotherapy is typically initiated within 6 to 8 weeks of surgery. Anything more than 3 to 4 weeks could be fine, as long as the wound heals well. And the chemotherapy is very standard. It is 5-FU or 5-fluorouracil-based chemotherapy. FOLFOX, KBOX, it's the name of the regimens, but it has to be 5-FU based chemotherapy. Any role for radiation for colon cancer? Typically not, but sometimes if a tumor has grown into the adjacent structure, especially ascending or descending colon, those two colon are part of the colon is fixed to the retroperitoneum, so we could radiate them. So we don't radiate transverse colon because it's mobile, it's not fixed. Or if a tumor presented with penetration, we could offer radiation to those people, as long as the area is fixed, and of course if there is if the margin is positive. So, what about rectal cancer? The story with rectal cancer is somewhat different. Any patient with rectal cancer should have pelvic MRI of the rectum, MRI of the pelvis with a coil to look closely into the rectal wall and regional lymph nodes. Endoscopic ultrasound is an alternative, and actually some use EUS more than MRI, but either one is fine. Then those tests are very accurate about the staging. Clinically, T1 lesion, that means is on T1 not reach the muscle or the serosa, of course. Those tumors, we can treat them with endoscopic resection only or local excision, so no need for a surgery with a colostomy for those. For a tumor that penetrate down into the muscle, a T2 lesion, those patients we treat them with surgery, either APR, abdominal perineal resection, or with colostomy, or low anterior resection without colostomy. Patients with a tumor that penetrates through the wall into the serosa or adjacent structure, retroperitoneum, peritoneal surface, or any lymph node, of course, involved, those are either stage 2 or stage 3, we do recommend treatment with neoadjuvant pre-operative therapy followed by surgery, and we'll talk about what kind of pre-operative surgery we mean. So, there are some studies, actually a lot of studies, done looking into the role of preoperative therapy versus upfront surgery followed by adjuvant therapy. And this is one of the studies. It is a German study done by the seminal German rectal cancer study group, and they looked into the role of preoperative or neoadjuvant chemotherapy versus adjuvant chemoradiation, and they found the preoperative chemoradiation provided superior sphincter preservation rate and lower rate of anastomotic stenosis as a long-term complication of pelvic radiation. And it has shown better local control while similar long-term survival. Now, chemoradiation is preferred given preoperatively, or what we call it neoadjuvant therapy. It is a concurrent, given together. before surgery for any of the three categories: clinically stage, clinically stage 2 or 3, that means a T3 or T4, this is stage 2, or end disease, that means stage 3. Any of those should be treated with concurrent chemoradiation before surgery. Or if a tumor is a T2, just reach the, not the serosa, so it's still stage 1, but the tumor is in the distal rectum, within less than 5 centimeters from the anal verge. So we do give chemoradiation with the hope of conversion of a PR with colostomy into a sphincter sparing low anterior resection, hopefully with colostomy. Or if there is a possible invasion of mesorectum or threatened circumferential resection margin. In that case, we do recommend chemoradiation. So preoperative concurrent chemoradiation is becoming the standard of care for stage 2 and stage 3 rectal cancer. So in summary, clinical stage 1, T1 or T2, the treatment is low anterior resection or APR without adjuvant therapy. However, sometimes we do recommend preoperative chemoradiation for stage 1 to preserve the sphincter, as we said before. So reverse or APR into LAR, low anterior resection without colostomy. Or if a patient is a poor surgical candidate, or a patient refuses surgery, the APR, say, I don't want to colostomy, I'm not going to do this surgery, then what do? We offer them chemoradiation, and it is their choice. Patient with this stage 2 or 3, we treat them either with the preoperative chemoradiation using 5-fluorouracil or capecitabine, which is an oral form of the 5-FU, plus radiation for 5.5 to 6 weeks, then surgery, which is APR or LAR, in 7 to 10 weeks, and then follow that by 4 months of postoperative adjuvant chemotherapy, combination chemotherapy, typically use FOLFOX or Zelox, regardless of the pathologic findings. What I mean by that, sometimes the tumor is there, you give concurrent chemoradiation, the patient goes to surgery, and the specimen is out, and the pathologist tells you there is no viable tumor anymore, dead tissue, scar, no cancer. That's what we call a complete pathologic response. Then we say, yay, we don't have to do anything, we're done. No. Those patients still they are at some risk of cancer recurrence, so we do complete the treatment and stay the course by giving the planned 4 months of postoperative adjuvant chemotherapy for 4 months. Otherwise, they are at risk of cancer recurrence. But of course, they do better. For patients who achieve a complete pathological response, they have more chance to survive the cancer. What about locally advanced cancer? Very big tumor has gone through the wall, reached the bladder, just adjacent structure, or a bulky big lymph nodes filling the pelvis. Those patients, we better treat them more aggressive than the other group of stage 2 or 3. I mean by that, by what we call total preoperative or neoadjuvant therapy. That means we give them the chemotherapy first. We reverse the chemo and radiation. So we give induction chemotherapy. Why that? Because those patients at risk of having micrometastases, cancer that already has gone into the bloodstream or the lymphatic system. So to get into those, we give them the aggressive chemotherapy first to deal with the distant disease, if any, and that's for up to 4 months. And then we do the concurrent chemoradiation. So we are done with everything now. And after that, 7 to 10 weeks, we go for the surgery. So the first one was done like a sandwich: radiation, chemotherapy, surgery, chemotherapy. Here we do everything before surgery. That's why we call it. That's why we call it total preoperative chemotherapy. So, what about patients? What about patients who has not received neoadjuvant chemotherapy, preoperative chemotherapy, for whatever reason? The patient end up in the surgeon, do the surgery. The surgery said, "I took it all. I'm done. We are good." No, those patients still they need adjuvant chemo radiation, even if TME performed. TME, total mesorectal excision. So those patients should be treated either in a sandwich way. That means 2 months of chemoradiation, 6 weeks of concurrent chemoradiation, 2 months of chemotherapy, or you do 4 months of chemotherapy followed by concurrent chemo and radiation. What if the margin is negative? Surgeon said, "I took it all. I took it all," and there's no lymph nodes, and the patient on top of that, the patient wishes to avoid potential toxicity of post-op radiation. Say, you know what? There is any chance that is I could avoid. There's any chance that I could avoid the concurrent chemoradiation. The patient asks that. What do we do? What do we tell them? Well, yes, we could. So for reassurance, we do run other tests. And there is what is called 12 gene recurrence score, Oncotype DX, that tell us more add actually more information and predict the risk of recurrence. There are other new tests. One of them is called Immunoscore. We'll talk about it later, or actually maybe in the next slide. And molecular residual disease, MRD. These are DNA tests. Also, they could give us more information. And if they are on negative, on low risk, then that patient could forego any toxic therapy after surgery. Here it is. The biomarkers for stage 2 and 3. There is now a test. It's called Immunoscore. Basically, this is done in the tumor. So we look in the tumor infiltrating lymphocytes, TILS. It measures the immune response at the tumor site, and it predicts risk of recurrence or relapse. Basically, here the report would be like low Immunoscore means high risk for recurrence, or high Immunoscore, low risk for recurrence. The other test, two tests, they are molecular residual disease test, MRD test. Basically, both these tests look for circulating tumor DNA, remnant, or if you will, like fragment of DNA or a little bit of DNA, not the whole cell. It could be in the blood. Those tests are so sophisticated, could detect remnant or part of DNA from cancer in the blood or in the blood, basically. So if there are, that means there is cancer somewhere, and we need to do something. Now let's move to metastatic disease that's gone beyond lymph nodes into other organs, typically liver for colon cancer. Lung also could be for colon cancer, and lung without liver for rectal cancer. The mode of metastasis of colorectal cancer is hematogenous, through the blood. I just mentioned that. The colon cancer typically goes to the liver, then through the portal vein, then lungs, then bone, and then anywhere else. On the other hand, distal rectal cancer could skip the liver, goes directly to the lungs, because the rectum is drained by the inferior rectal vein, which drains into the IVC, inferior vena cava, rather than going through the portal vein, and that's why it may end up and land into the lungs and skip the liver. So, metastatic colorectal cancer. Few words about it. 50 to 60% of colorectal cancer patients will develop metastases at one point during their journey fighting this cancer. 15 to 20% of metastasis is synchronous, discovered at the same time at the time of diagnosis. And unfortunately, in that case, 80 to 90% of metastasis is unresectable. On the other hand, the majority of metastasis is metachronous, cancer recurrence, metastasis later on, after surgery, after adjuvant chemotherapy. It's a failure. They develop disease later on. This is the most common, and that's mainly in the liver. So, if the patient with the synchronous liver metastasis, if the patient presents with synchronous metastatic disease, and the tumor, of course, is intact, and the liver has mets, what do? Colon cancer, everyone says surgery. No surgery for colorectal cancer with metastases. No surgery, unless the metastasis is so small that could be removed at the time of surgery, and that's not the common scenario. So, if there is metastasis, no surgery. Why? Because if you do colon surgery and leave the metastasis, there is a delay of treatment, and then the cancer keeps growing. So what do? Go with systemic treatment. The only time, and the only time, surgery for the primary tumor to be removed in two conditions: acute bowel obstruction or significant bleeding. I'm not talking about blood in a stool, those kind of things. I'm talking about hemorrhage. If the patient is hemorrhaging or presented with acute bowel obstruction, then, well, we don't have a choice. We have to do the surgery. Surgery here is not done as treatment for the cancer. It's done to relieve the obstruction or to stop the bleeding. So no surgery for metastatic colorectal cancer unless there is an emergency. Or if the metastasis could be removed easily, so limited metastasis could be done, and still the best is not to do surgery. The best is to do systemic therapy for micrometastases. As we said, the metastasis typically in the liver for the colon cancer, more than 50% of patients died of colorectal cancer have liver metastasis at autopsy. So it's kind of common. Liver metastasis is the cause of death in the majority of those patients. In 30% of the cases, liver as the only site of disease. So because of that, people look into treating the metastasis aggressively, remove it if possible. Without surgery for the metastasis, the 5-year survival is very low. And in selected patients, resection of the liver metastasis could lead to cure. Yes, could lead to cure. If you remove the metastasis from the liver, and those patients could be cured. So the 5-year survival was reported up to 50% for resected liver metastasis. So how we treat liver metastasis? Liver resection currently represents the only potentially curative therapeutic option for hepatic colorectal metastasis. And the 5-year survival rate of 25 up to 58% have been reported. So, Because of that, potentially resected liver metastases become standard of care. If there are less than 4 metastatic lesions, partial resection is the best option, of course, in selected cases. And that leads to 5-year relapse-free survival rate of 30% and 5-year overall survival of 58%. If there are more than 4 liver lesions, or the lesions are bipolar, you have 2 here, 1 here, 2 lobes, even are 1 on 1, those patients, or if there is portal lymph node involvement, those patients should not take them to surgery, and instead we treat them with neoadjuvant chemotherapy, give them systemic chemotherapy with biologic agents, and then take them for surgery after evaluation, of course. Potentially resectable liver metastasis from rectal cancer is treated a little bit different from colon cancer. There are 2 strategies. Either of them is acceptable. Either we could start by giving the patient combination chemotherapy followed by a short course of radiation or a long course of chemoradiation. Then we take the patient for resection, either synchronous, remove the tumor from the rectum and from the liver at the same time, or staged by doing the rectal surgery first, and then later on we do the hepatectomy or metastasectomy from the liver. Another strategy, basically we just reverse the sequence of radiation and chemotherapy. So here we could start by concurrent chemoradiation or a short course of radiation, especially if the rectal tumor is symptomatic. So radiation will help for the local control. And then we give the chemotherapy. After that, we take the patient for the surgery, which also could be synchronous or staged. So, selective internal radiation therapy, SIRT, or radioembolization. You may heard of chemoembolization, when we inject the chemotherapy into the tumor. Here we inject radiation microspheres into the radiation and start giving radiation within the tumor. It's kind of a new strategy of treating metastatic liver disease. Here we use the Y90 resin microspheres, and it has shown benefit. What about systemic therapy? New drugs has changed the natural course of colorectal cancer by improving the disease-free survival as well as the overall survival. 5-FU, 5-fluorouracil, historically has been used and has improved the survival, but not much. Increased survival by 11 to 12 months. However, the new drugs, oxaliplatin and irinotecan-based regimen, has been reported in multiple studies to give an overall survival up to 3 years. In addition to that, by adding biologic agents, the overall survival has improved, and now we could see a 5-year survival up to 20 years. So patients with metastatic colorectal cancer could enjoy long-term disease-free survival by using new drugs and biologic agents. Here are the options of cytotoxic chemotherapy. Folfoxiri, this combination of 3 drugs and vitamins, or 2 drugs and vitamin, Folfox, Kbox, Folfiri. This is just, don't worry about them, it's just the name of the regimens, but these are toxic chemotherapy. This is my favorite slide because these drugs has changed the natural course of cancer in general and colorectal cancer specifically, because nowadays there are patients that enjoy long-term survival. In addition, they don't have to go through chemotherapy with the side effects, losing hair, nausea, vomiting, all bad things we hear about it about them related to cytotoxic drugs, so biologic agents. But it's not for everyone. The cancer has to have the target for them. Say, so left-sided colorectal cancer, which are sometimes they're KRAS and BRAF wild type. We treat them with anti-EGFRs, cetuximab, plus, but still we use chemotherapy. But hopefully we could eliminate chemotherapy and use all biologic agents. Here, for example, in a KRAS wild type and BRAF mutated, we don't use chemotherapy. We use two biologic agents. One of them infusion, one of them is just pills, tablets, and side effects are so minimal. Right-sided colon cancer, typically nowadays you treated by anti-VEGF, bevacizumab, and chemotherapy still, but cancer that are deficient in MMR or MSI high, those we treat them with checkpoint inhibitor, PD-L1 inhibitor, immune therapy, not chemotherapy. And by the way, these drugs could be given for a long time, and they don't have to. So we give them until disease progression or unacceptable toxicities. So they are not like chemotherapy. We give certain cycles, and then you have to stop. Tumor that overexpress HER2 are treated with anti-HER2. And HER2 is a drug which is a non-chemotherapy drug for this group of patients. There's another biologic agent, is the Varga, is a VEGF antagonist. Peritoneal carcinomatosis, bad disease. The abdominal cavity, peritoneal cavity, field of disease. There is nothing that you could just cut out. So what do we do for this patient? If the peritoneal carcinomatosis is isolated in less than the 13 peritoneal quadrants and few areas less than 5 centimeters in size, those patients, those selected patients, may be rendered cancer-free by surgical site reduction, very extensive, delicate surgery, just basically scrape and remove all kind of visible tumor, and then use HIPEC, hyperthermic intraperitoneal chemotherapy, and that is could render them cancer-free. The median survival has been reported up to 5 years. So after all, now we treat the patient, and now we need to keep an eye on them. Surveillance. After we finish the surgery, adjuvant therapy, all kind of therapy, a year from the initial surgery, and from the surgery, we should repeat a colonoscopy a year from surgery. And if, but if no colonoscopy was done or incomplete colonoscopy, then we repeat the colonoscopy in 3 to 6 months. If you find no advanced adenoma, we repeat colonoscopy in 3 years, then every 5 years. But if we find any adenoma on the repeat colonoscopy, we do another colonoscopy in a year. For stage 2 and 4 disease, those patients, we see them every 3 to 6 months for physical exam, history, physical exam. We do labs, CBC, liver function, CEA every 3 to 6 months for 2 to 3 years, then every 6 months for 3 to 2 years, and then annually. Also, we may do CT scan every 6 to 12 months for 5 years, depending on the stage. I may consider genetic biomarker. It is again circulating tumor DNA. It is a blood test. More than 80% predict actually specific if there is cancer recurrence. So it's not perfect, but 80% is not a small percentage. Also, we may monitor those patients by doing molecular residual disease test, MRD. Signatera detect circulating tumor DNA. It is done in blood and tissue for accuracy. So, Guardant reveal test is a blood test, also detect circulating tumor DNA. This table just shows the 5-year survival in colorectal cancer. You can see stage 1, the 5-year survival at 96%, goes down, 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 and now 8% for stage 4. This is the 10-year cancer-specific survival rate for rectal cancer. You can see 89% stage 1, 11% stage 4. This is a slide for people who like pharmacology. 5 fluorouracil. Interestingly, it is considered mild chemotherapy, but it could be very toxic to some patients. Those patients who have DPD deficiency, dihydropyrimidine dehydrogenase deficiency, and or thymidylate synthetase mutation. If they do, they may end up in the hospital with severe toxicity, like mucositis, severe diarrhea, even neurotoxicity. It could be fatal because they don't metabolize this drug, and the drug just almost like giving them overdose of 5-FU. And there is a test actually for these enzymes. It's called Theraguide 5-FU. It tests the TYMS and DPYD. It's not very rare. 25% of patients may have them, and the risk of severe life-threatening toxicity is also not small, up to 60%. Another common drug used for colorectal cancer is irinotecan. Due to accumulation of the active metabolite SN38 in the intestine, some patients may develop toxicity. If they have the enzyme UGT1A1 mutation, especially if it is homozygous, they could have severe toxicity, mainly diarrhea, myelosuppression. Last, I promise this is only 2 slides. I'm sorry it's taking too long, but there are 2 slides to finish the large bowel. I thought it just better to mention anal cancer. It's not very common. We see this in HIV patients sometime or non-HIV. So anal cancer, there are 3 types of anal cancer. Either anal canal cancer, it is either keratinizing squamous cell carcinoma. Remember, it is not adenocarcinoma, it is squamous cell carcinoma, arise in the transitional squamous mucosa below the dentate line. Or non-keratinizing squamous cell carcinoma. This is more aggressive, basaloid, junctional, or cloacogenic, arise from epithelial transitional zone above the dentate line. Or adenocarcinoma. But if we see an adeno, it is a surprise. It's not very common. So we treat this as rectal cancer, not like anal cancer. And then there is an anal margin cancer, which is perianal skin cancer. Perianal skin cancer arise within the skin at or distal to the squamous mucocutaneous junction, the anal verge. And it has to be within 5 centimeters from the anus, so it is in the perineum. And then primary rectal squamous cell carcinoma. Well, I don't know if it's truly rectal, but as long as it's squamous, we treat it as anal cancer. So, treatment. Treatment of anal cancer is different from other cancer. Typically, surgery is the treatment of choice for cancer in general. Except for anal cancer, we do not recommend surgery because, number one, there is another alternative which is as good as surgery. Number two, doing surgery for limited disease make the patient end up with not a good quality of life, because for a small tumor we have to remove the anal canal, and then they don't have a sphincter, then they have to have a bag, colostomy bag. So 5-FU, mitomycin with radiation given together over a period of the chemotherapy in 4 weeks, and the radiation may extend to 6 or 7 weeks. Those patients may end up with a complete clinical response in 6 to 12 weeks. Done. So in 11 weeks, 60% are disease-free. 85% still may end up with the no evidence of disease in 26 weeks. So that means do not rush for salvage surgery if still there is clinically some evidence of tumor in the anal canal after the concurrent chemoradiation. So be patient and wait longer. For recurrent disease, of course, we do surgery. Then there's no other choice. We do APR with colostomy if the cancer comes back, concurrent chemotherapy fails. For metastatic disease, the choice is on 5-FU and cisplatin, platinum, carboplatin or Taxol, may be less toxic. The second line is PD-L1 inhibitor, checkpoint inhibitor, regardless of the PD-L1 status, and we use Pembro or Nivolumab, Keytruda or Opdivo. These are immune therapy. They are not chemotherapy, but still they're the second line. Hopefully they will be front line, first line for metastatic disease because they're not toxic. They're not that toxic. They're not chemotherapy. And I guess take-home messages. Number 1, be aware of colorectal cancer symptoms. And remember, not all hematochezia, rectal pain, or tenesmus are symptoms of hemorrhoids and or dysentery. Also, not all irregular bowel habits are due to IBS. Second message, colorectal cancer could be cured if detected early by screening colonoscopy. And remember, an average person should start colonoscopy at age of 45, then every 10 years if normal. And high-risk patients could start colonoscopy as early as teenagers and then more frequent. Message number 3, not all metastatic colorectal cancer is a death sentence. With new diagnostic and therapeutic procedures and effective drugs, including biologic agents, many may enjoy years of survival compared to the historical survival of a year or less. And last, few patients could be cured nowadays. Thank you so much. I'm sorry for a long session. It is very difficult to cover colorectal cancer in 1 hour or so. So if any question, I'm available.